If I were to talk to you a month back, everybody was in crisis. People were not getting beds. Hospitals were full. We were out of supplies. We understand this was a disaster, but can we also not believe that this disaster was, a constant failure of our healthcare system?
Now, this is a wake up call. Hopefully, God willing, the health and wellness centers, the Ayushman Bharat scheme, the Pradhan Mantri Jan Swasthya Yojana, and all these schemes now will penetrate.
Hello, all. Today, this is a very important episode where we have with us Professor Dr. Anil Dewan. Professor Dr. Anil Dewan is a professor in the Department of Architecture at School of Planning and Architecture, New Delhi. He has over 3 decades and more of experience in teaching healthcare architecture. His PhD was in hospital standards, and he has been a consultant at the World Bank and also been consulting at the Bureau of Indian Standards to make hospital standards. He's also the vice president of the Institute of Hospital Engineering in India. We welcome you, sir.
Thank you, sir. Thank you for your kind introduction.
Thank you. Thank you. So, sir, we are just, at the ebbing phase of the second phase in Delhi of the coronavirus. If I were to talk to you a month back, everybody was in crisis. People were not getting beds. Hospitals were full. We were out of supplies. We understand this was a disaster, but can we also not believe that this disaster was, a constant failure of our healthcare system? So, sir, I'm going to ask you a few questions because you're an expert in hospitals and you've been attending a lot of webinars, seminar, and you've spoken at a lot of healthcare related conferences. My first question to you is, sir, as India transitioned from a constant lowering of healthcare budget by the government, do we now bear the brunt when we have to use crumbled dispensaries and primary schools for things like vaccination, testing, and providing primary healthcare?
Okay, let us talk about the health systems in India. The healthcare delivery system, if we put it in the right perspective, 70% of the population of India lives in the rural and tribal and urban slums of India, and 30% of them live in the urban areas. While all our health budget is spent in the urban areas, and about 30% of the population lives in the urban areas. So there is this mismatch at this level itself. Now, in this phase, the coronavirus is reaching the peripheries. It is reaching the tier 2, tier 3 cities, rural areas, and tribal areas. There it is the community which has to look after itself. The facilities are abused, misused, disused, unused, or not usable. So, service delivery cannot happen there because the healthcare personnel don't come there or are not available there. The medicines are not there, the supplies are not there, the medical gases are not there, electricity is not there, water is not there. So these are the problems we have there. So now is the real test that is going to start. There are no blood oximeters, no thermometers, very basic elementary things which are now almost in each of the households. So what are the positives that we have got till now? In the urban areas, people at home are talking of things which were not there before. Telemedicine has been accepted. People are doing teleconsultations. There are almost some families which have set up ICU facilities at home where old parents and grandparents are taken care of at home. But in the rural areas, now this is a wake up call. Hopefully, God willing, the health and wellness centers, the Ayushman Bharat scheme, the Pradhan Mantri Jan Swasthya Yojana, and all these schemes now will penetrate. The
So
media glare goes there when the
absolutely.
people are more aware
Absolutely,
and things
absolutely.
start happening.
So you spoke about the Pradhan Mantri Yojana that we just spoke about, which will reach the rural areas, which has reached a lot of states. So that is the insurance-based models. And today we see that, the insurance model, 40% of the expenditure for a COVID patient is being borne by the patient themselves because the insurance does not cover a lot of consumables and other things. So the figure has reached up to 40%. You know, in the rural areas, if we have an insurance based model, will that really work when patients have to pay 40 to 50% from their own pockets?
See, the out of pocket expenditure on healthcare in India is amongst the highest in the world. It is a well known fact that when somebody falls ill in the family, the people get into a poverty loop. We in Delhi AIMS, outside Delhi AIMS, are always seeing patients who are so poor that they could either eat their food or eat the medicines. They cannot do both. There are so many people who come outside AIMS and they are distributing free food to these people all the time so that they may be able to buy the medicines. And now there are these pharmacies which are generic medicines which are now cheaper. So now what is happening? People are finding that look at this injection. It is so expensive. And if it was generic, it could have been produced at a much lower cost. So the cost of pharmaceuticals, the cost of consumables, the costing of healthcare now is being observed, and people are saying that for poor third world countries, there should be some solutions which will make healthcare affordable
So sir,
and
you
available where you are.
so you've spoken about what should be there, but as we speak about the first wave that happened in China, they developed hospitals so quickly, within days, within weeks, and these hospitals were made of prefab structures. And in India, we are developing tent hospitals, 500 bedded, 100 bedded, 200 bedded. So do we not have the technology? Do we not have the capability to have hospitals which are not just makeshift hospitals, but which can be actually be used even after the pandemic, of prefab structures and other technologies?
Very fair. So these are surge capacities. Now in Delhi, each of the hospitals are saying, give us space where we can generate our own oxygen. So they're saying that the master plan of Delhi, the development controls of hospitals, they should permit us to put a oxygen plant. They should give us in the parking lots and all, we should be allowed to do a temporary structure wherein the surge expansion can be taken off. So now there is a requirement of patients who are non-COVID. Lot of these cancer patients, lot of these chronic diseases, lot of the other surgical patients are now not able to use the healthcare facility because it is being converted into a COVID hospital. Let us
Absolutely.
talk about the National Cancer Institute, the trauma center in AIMS. They've all been converted into a COVID hospital. So, what happens to the general public? So, your question about China developing this, we in India in the first wave had also developed a lot of this, what we call in the army as field hospitals, wherein you have some kind of a temporary structure. But in the second wave and the third wave, the requirement is of oxygen, lots of oxygen, ventilators, ICU beds, and high dependency beds. So, merely a bed is not enough now. We want oxygen supply, oxygen there. So, bed with oxygen is minimum that is required. An ICU bed with ventilators is what is going to save lives. So that is possible to do in field settings. And in future, we have to design the services in such a way that they could be plugged in to the existing facility to where. So we have a point from where you can take your services, plug and play kind of things, and you do surge expansions and you keep them. Something like a disaster expansion systems with each of the hospitals. So
So
then we'll have to segregate the hospital in two places where infection and non-infection and negative pressure, positive pressure, all those things
no, sir, thank you. You're
for a
talking
long
very
answer.
relevant,
So
very
we have the
relevant.
capability, we have the technology. Yeah.
So very relevant. You were talking, and you just came to
So
design. So how can architects train themselves as far as conceptualization, design, and implementation of rapid movement construction is concerned? Because there is going to be a boom after this pandemic of healthcare infrastructure in India. How should they prepare themselves?
okay, so architects have to be aware of infection control measures in hospitals. That infection or hospital acquired infection is not only from a patient to doctor, doctor to doctor, patient to doctor, nurse to patient, and not. So it's not just a touch which carries the infection from one person to another. It is the airborne infection, it is the aerosols, it is the infection which by architectural interventions and at planning stage may be prevented and reduced. So we have to do isolations with negative pressure. So we have to ensure that the air from one patient does not go to the next patient. We have to ensure that a COVID patient and a non-COVID patient are not treated to next to each other in a hospital setting. So these measures, systems, operating procedures, and architectural and building professionals interventions, which means the engineering, the detailing, the heating, ventilation, and air conditioning systems, and the electrical systems and medical gas line piping systems have to be designed such. So the oxygen system does not fail. The oxygen is there for each patient. So we have to make sure of double lines and double supplies. So one fails, the other takes over.
Absolutely, sir. With your many years in the academic sector, in the teaching sector, you have been teaching a lot of students. So, you also go to a lot of colleges in India, architecture colleges in India, to, to be their jury member. So I want to ask you, are the architecture colleges in India doing their job and training at the undergraduate levels for producing good healthcare architects?
Very good question, I must say. So, what has started happening is that in the 5 years in an architecture college, all the students get at least one healthcare project. So, mostly in third year, a lot of colleges have a hospital project. And there are electives or in theory of hospital design, a hospital elective as a theory subject is also offered in a lot of colleges. Plus, we've had this Arpit Swam teachers training program, which a lot of students could also take. So that on YouTube or on Swam portal or Arpit portal is available. So the resources are available. Maybe we don't have enough teachers in all the 490 or 400 odd colleges in India. Maybe the syllabus is there, the course content in there, but experienced, knowledgeable teachers who have gone through the grind are not there. So
Okay.
it is not the ideal situation, but post COVID, it is going to happen. From
So,
first year onwards, they will get into teaching.
so in some colleges, there is this practice that students, choose between a hotel and a hospital because both of them are service-oriented buildings. So, should not be healthcare
Yes.
buildings be universalized, yet that every student of architecture should absolutely study a hospital design? Because right now there's an option available.
See, in that is in SPA, we have a choice-based studio wherein we have a hospitality studio, a housing or a large fan structure in a hospital studio. So I hope that now the awareness for the hospital elective would be increased. Students would take the hospital design studio. I am very clear about it. So the awareness is increasing, and hopefully we should have a positive frame of mind.
But sir,
Yeah.
positive
So
frame of
things
mind
will
is
improve.
excellent, and but still there's a choice that students have, where there will be some amount, some percentage of students who will not be trained in healthcare architecture. Should it not be made into a compulsory design subject, sir?
No, what happens is when they do first year exercises, second year exercises, third year exercises, there would be some component of healthcare. And there's a lot of peer group learning and learning from each other. So they learn from their peers, and not everything can be taught in 5 years to all the students. We teach them how to learn, and then they learn on their own. So when they get a project, they'll start learning then, and hopefully they learn. I have high hopes on the way we teach and what we teach, and they will get it. So this learning is going to happen. What is
Absolutely.
a worry is that we need our students to do community service, social work, and whatever they are good at this stage. Now they should help the community, whatever way they can.
Absolutely,
That is
absolutely,
very important
absolutely.
today.
So, sir, as the leading healthcare architect in India and as the leading academician of healthcare architecture in India, what is the message that you want to give to all architects, architecture students, and everybody else listening to this video?
Yeah. So what I want to say is, let us get into multidisciplinary modes. So like in a hospital, there is a hospital infection control committee where the microbiologists, the hospital administrators, the ward nurse, the nurses, the paramedics, everybody gets together and they see how does the infection go from one place to another. We in the architecture departments also have to get in close contact with the plumbing consultants, the HVAC consultants, the electrical consultants, and the medical gas pipeline systems, the pneumatic gas systems, as to where, what are the coordinations which we have to do, and we have to learn from all the other disciplines. And so it is a team effort. So we have to form multidisciplinary teams, and we have to respect each other's contribution to making safe, efficient, and working hospitals. Now things are not working.
Absolutely,
So we
absolutely,
believe in God and we pray to God that things improve. So this is
absolutely.
a chance. The budgets for healthcare are going to improve a lot. The awareness is there. People have lost their near and dear ones. So there is a lot of anger in everybody's mind. So we have to channelize these energies into a positive direction.
Absolutely, sir. You have given a lot of enlightenment on healthcare architecture, from the basics of the healthcare policy to, making makeshift hospitals, to telling us all about how in the architecture colleges, healthcare architecture should be taught, to whom it should be taught. So a great coverage has been done today. I really, really thank you for sharing this very, very important knowledge with all the participants. Thank you, thank you, thank you very much, sir.